SEMA is all about before we have the opening remarks. Which side should I start with? I will start with here. So please tell us your name and organization. There, okay.
Good morning, everyone. I'm Clara Namidi, working at the Ministry of Health, Directorate of Health Products and Technology.
Good morning, everyone. Caroline Asin, also from the Ministry of Health, Health Products Directorate.
Morning, Dr. Jared Nyakiba, MOH, Director of Health Products and Technology, DHPT.
Lucy Meka, Ministry of Health, DHPT.
Good morning, Miriam Mwikali, Ministry of Health, the Directorate of Health Products.
Morning, everyone. Eunice Gaditu, DHPT, MOH.
Good morning, everyone. My name is Miriam Biti, MOH Health Financing. Thank you.
Good morning, all. My name is Samuel Onsongo from the Ministry of Health, Division of Healthcare Financing.
Good morning. My name is Dorothy Iwak, Kenyatta National Hospital.
Hamjambo wote. My name is George Walukana, Kenya Medical Supplies Authority.
Good morning, everyone. I'm Tabitha Okech from Center for Epidemiological Modeling and Analysis. Nice to have you all here.
Good morning. My name is Jeanette Dow. I'm the Scientific Manager at SEMA.
Good morning. I'm Paula Kristen, a postdoctoral fellow at SEMA.
Good morning, everyone. My name is Andros Gitao, Ministry of Health, Director of Health Products and Technologies.
Athanasio Japheth, Directorate of Curative Services, MOH.
Good morning, Edwin Mtendwa from the Division of Health Financing. Thank you.
Good morning, name John Maina, DHPT, MOH.
Good morning, Beatrice Cheriot, Pharmacy and Poisons Board.
Morning, Sarah Mwangi, Ministry of Health, Directorate of Health Products and Technologies.
Good morning, Dr. Nancy Jeru, Directorate of Health Products and Technologies.
Good morning, everyone. Abia Kevin is my name. I think for now I'm a freelancer up to 30th. I was working with the Chemonics, but I don't feel like often have been adopted by DHPT. Yes.
Morning, everyone. My name is Richard Gatukui from the Directorate of Health Products and Technologies. Thank you.
Good morning. My name is Ida Umbura. I'm from the Directorate of Health Products and Technologies.
Good morning. My name is Ruth Muya, Minister of Health, Directorate of Family Health.
Good morning. I'm Anthony Mwanje from ICT.
All right, good morning. My name is Brian Lugonzo, ICT for SEMA. Thank you.
Thank you. If you look at your notebooks, we have the program there, the first few pages, and you can be able to just look at what you expect for the different days. It's all printed there. I will now take the next few minutes to just tell you what SEMA is all about. Just to reiterate, so SEMA is, in full, it's the Center for Epidemiological Modeling and Analysis, and it's a center of excellence at the University of Nairobi. The center focuses mainly on data analytics and modeling with the aim of aiding health decisions. And we mainly support the departments and ministries at the government and also the Ministry of Health, where we try and bring out the evidence that is used in decision making. We use a multidisciplinary collaborative approach where it brings together computer scientists, data scientists, pharmacists, clinicians, all with the aim of providing evidence to be able to provide evidence for decision making for policymakers. And this is because we see that when you're trying to control, eliminate a disease, it's a very messy affair that you need all different disciplines to be able to sort that problem. We also do training, and this is one of them, for modeling and data analytics. And our core support comes from the Gates Foundation. We usually have three main catalysts for the center. That's the people, the work, and the support. And when we start with the people, you can see that the team is fairly young people and just bringing together people from different disciplines. And the thematic areas we have is mainly the ones in blue are on applied epidemiological modeling. And that's the health technology assessment, primary healthcare, NTDs, zoonotic, and also infectious diseases. And then the ones in orange are mainly the ones that focus on clinical trials. That's on HIV and AIDS and also on antimicrobial resistance. With all these thematic areas, we also do data collation and also training with the aim of increasing the capacity in the country and also in the continent. The support we have is both institutional support and also in terms of resources. When you look at the institutional support, is one, as I earlier mentioned, we are anchored under the University of Nairobi, and that we now get a lot of support from the university. And we also have membership for other consortiums where we are a member of the International Clinics on Infectious Disease Dynamics and Data, and also under the NTD Modeling Consortium. Our resources, the main resources come from three funders. That's the Gates Foundation, Wellcome Trust, and the Denmark Development Corporation. We hope that as we go through this training this week, that as much as we focus on the health technology assessment, we're also open to any other thematic areas that you'd like us to work together and also find solutions for. So I will now move to the next session of welcoming Dr. Tom Menge to give the welcoming remarks.
Good morning. First of all, I really want to acknowledge the effort to put this training together and the effort that has really been, as earlier indicated, been really primarily by Dr. Nancy Njeru and Jared. I know that they've worked very hard to make sure that we all leave the offices and have opportunity to sit here together. I also want to acknowledge that within this setting, we have a lot of people that have joined us from various other directorates and other departments of the Ministry of Health. And I believe that it's going to be an opportunity for us to, first of all, get to know one another, but also work together through this very intense training. And I also like the book. I think it's something that you're going to adapt with our partners in future, so I'd like to keep it. I never knew that my name would be on a notebook. But for the various representatives from SEMA, thank you so much for coming on board to help us work together. We will be having representation from the Department of Pharmacy in Ghana, and I believe that that will also be quite well acknowledged. We have various directorates of the Ministry of Health. We've got various sagas under the Ministry of Health. I'm able to recognize Kenyatta National Hospital, my primary employer, and also KEMSA, and Pharmacy and Presence Board. We also are grateful for a gentleman that you've sort of adapted. We look forward interacting with you in future. But I think one of the most important thing is that for us is a very important exercise as the Directorate of Health Products and Technology. There's been a very big desire for us to be able to institutionalize the concept of health technology assessment through the various ministry policies. And this is just one step in that direction. And when you think about something as big as HTA, then you really need to look for the expertise that can be able to bring you together so that we can be able to move forward together. We were catching up with Tabitha a short while ago, and we went back to about 3-4 years ago during a HOPAC symposium, where the concept of HTA was still very, very foreign, and I'd been given the responsibility to co-chair a committee in the Ministry of Health. And at that time, Tabitha had not gone for training. She's going to be teaching us things that she picked up during that time and is now professional in that area. And we asked ourselves the question, how important is health technology assessment for any decision that can be made? And therefore, when we come together as the Directorate of Health Products and Technology to really think about HTA, it is for me a dream come true. We know that under the ministry, we have the ministry's Health Technology Assessment Strategic Framework. But if I ask any of you how much all our activities are embedded in the HTA strategic framework, there are a lot of gaps. Yet if you look at the framework and you look at the opportunities that it offers and the answers it can give us, they are immense. Again, if I could ask what each of us understand by HTA, it's one of those miscellaneous things where you don't even know where to place it in the whole concept of healthcare. Is it a health financing tool? Is it a HPT tool? Or is it one of those miscellaneous things that Nancy Njeru likes talking about and specializing in? So where does HTA come in the decision-making process? And when we're thinking about this, there are 3 areas that I just want to mention about. In the past, when you look at how medicines are managed, medicines are entirely managed as commodities that should be included in like the NHIF packages. I remember a few years ago when I was at Kenyatta National Hospital, when we were trying to do the theater packages, one of the questions that we were told, can you determine every medicine that is going to be in every major or minor operation so that as we're doing the costing for that procedure, it's going to be incorporated within the cost. And that offers a problem because it means that pharmacy is looked as a service that is embedded in other processes. And you actually end up losing out. So that if somebody goes for a major operation, let's say a cesarean section, it's not considered that the medicines that could be used are distinct for every single patient, but it should be a package that should be there. And as we move on, a pharmacy really needs to be distinguished as both a service, but also products. And the products are unique for every single case. And therefore, the first concept is for us to look at health technology assessment as being something that sort of brings together health financing and the Directorate of Health Products and Technologies. We'll soon be doing a pharmacy benefits package. And one of the challenges about the pharmacy benefits package is how do we understand it? A few months ago, and I think Nancy and Jared can be able to remember this, we engaged the Pharmaceutical Society of Kenya. And we asked them, we want to sort of like lead the process of the pharmacy benefits package. And could they give us their input? Let me just say that whatever they gave us was completely underwhelming. They gave us an Excel sheet that just had that for a pharmacist, this is how much you'll pay them per month for offering services. And it was a bit embarrassing to think that that is how some of us view the pharmacy benefits package. And as a result of this exercise, we'll then be delving into having a costed pharmacy benefits package. I think one of the questions that we even ask them primarily, that even before you go into that, NHIF requires a health facility. Have we even considered that pharmacies should be registered as health facilities as a beginning point? And then how can we be able to justify, what is the calculation that you'll be able to do to show that whatever you're offering as a service within a pharmacy has got health outcomes? Now, those are the things that you're going to go through this week to have a better understanding about, so that as we move into the next phase of the pharmacy benefits package, of which I see several of you actually are in that group that is going to work together for us to be able to come up with a pharmacy benefits package, then it will be based on science. The other area that I just want to talk about is that over the past few years, we've been very, very key in coming up with what we call HPT policy documents. And they become very critical in guiding management and the use of HPTs in the health sector. We have developed essential lists. And we believe that those are some of the most important HPT policy documents that are currently in circulation. The essential lists have been very good in guiding things like procurement and also access to HPTs. They've given us a basis under which you can say that these are the things that the Kenya Medical Supplies Agency, for example, can be able to concentrate on. But we find that they have not been utilized to argue out, for example, insurance reimbursement. So they're just documents that can guide procurement. They are able to guide us in the area of access. But insurance companies, for example, even the NHIF, has not considered that that is the document that they need to use. I remember when we were really discussing about SHA, they started coming up with new lists. And we had to tell them very, very clearly that we already have the essential medicines list, the essential medical supplies list, and we are not deviating out of that. In addition, the essential lists have also prescribed at what level the items are going to be available. So that is work that we've already preempted and gone into, and we shall not be able to go back. And therefore, as we go through this process, I believe that HTA is going to lead us to a way where we can be able to argue out how insurance reimbursements can be linked to the essential lists that we already have. I know that later on this month, we'll be reviewing the KEMSA essential lists, I think at the end of this month, and really looking at our documents and seeing how procurement and all other issues can be linked to the list that have already been produced. The third area that I want to talk about is on the area of healthcare costs and the spending on healthcare. We know that there is a very large out-of-pocket expenditure for almost all our households. Indeed, the Kenya Health Survey said that 25% of healthcare costs comes from out-of-pocket. And a lot of that is in the area of HPTs. Now, how can we be able to contain and reduce the out-of-pocket expenditure, especially for people who consider that they're already insured? How can we be able to justify that? It has to be through a scientific process. We actually need to go through a process that can demonstrate that we can be able to have a health system or a financing health system that can be able to protect the population against the risk of the high financial costs. And all of that really needs to be through a system like what we are developing today. The final thought is on how we have managed healthcare in the past. Healthcare has mainly been opinion-based. are not evidence-based. And therefore, even a prescription in its basic design is a doctor's opinion on how you can be able to treat a certain disease. Very few of them are actually evidence-based. How could it be possible that for us, we can be able to look at even the documents we've done and say that a lot of this is actually based on evidence? And that's what HTA is about. It requires a lot of scientific knowledge. I was warning some of my colleagues that this is going to be as an intense a week as we had about a month ago. I remember when we were doing a scientific process of quantification and forecasting and quantification. I've never seen my colleagues in DHPT as stressed as they were during that week of extremely intense work. Because for you to be able to quantify something, you have to use evidence, you have to use a lot of maths, and you went through a very intense week. Now, if that was intense, I don't think we've ever done a training with as many computer models or computers as we have in front of us. And even if you came with your laptops, maybe it's because you felt you needed to use two. And I welcome you to the challenge that is ahead of us. So I'd like us to use science. I'd like us to delve into this study. And if you looked at your timetable, it is intimidating enough. But this is the beginning of a process. And therefore, as we work with our colleagues from curative services, from health financing, and so on, we are really open to work together in a very, very broad way to ensure that as we are delving into the area of management of health products and technologies, then we are, first of all, working with colleagues. But secondly, whatever decisions we are making, they are based on a very sound scientific principle. So I wish you a good week. And I have chosen to not participate in that very intense training, but I will be with you for the opening remarks, the dinner, and the closing remarks. And in the meantime, I wish you a very, very successful week. It's my pleasure to declare this meeting open. Thank you. I was not advised to hand over this microphone to.
Thank you for the good opening remarks. We now want to dive deep and start the training. And I'd like to welcome Tabitha. Okay, she's coming. Okay. Okay, you help us set up.
morning, everyone. My name is Noel Ikalamu. This is my colleague, Waidera Mwangi. We are the administrators here for the training. So in case of anything, you can come and see us outside. So I just wanted to give you a brief of the area. Like for the washrooms, I know majority have seen at the back here. And then the timings for lunch, for the tea, the 10 o'clock tea is at 10:30. And then we'd have also another tea at 4 p.m. For lunch, we'll be having our lunch at Nairobi Safari Club. So we'll walk out, we will take you in 2 groups. It's just across the road so that you can have some bit of exercise. I don't know if there's anything else I've left out. Do you have any questions? Have I left out anything? You good?
Thank you. Thank you, Noel.
Yes.
What is the parking arrangement? Because the morning when we came, it was a bit
Yes, about that, just because they didn't have like your name tags. So from tomorrow, please ensure you have your name tag, because your name tag will be like your entry for into the university. So they'll just direct you where you're supposed to park. I'll confirm with security which one they've set aside, and then I'll let you know in the course of the day.
But it's highly likely it's going to be the one at 844 because it's larger. The one after the JKM side. Go straight ahead and on Uhuru Highway. On Uhuru Highway there is a turn there, so you can turn from the JKM side. The 844 parking.
And one more thing, I just wanted to let you know there's some planned demonstrations by the students today, but let you know you're safe. The security, you can see there was a number of policemen around, so they've ensured that we'll be safe. Even as you go for lunch, we'll be okay.
Also informs that
So don't
844 parking is not working. So you come and use the one on University Way. They'll direct you now to the one that you come in through this one, the one straight ahead here, then you join. Yeah, we'll make the arrangements. Us, we may be safe, but the vehicle is safe.
Thank you, Noel, for housekeeping. We have raised our blood pressures a bit, but yeah. Everything is okay and safe, so no need to worry. At least we have the heads up. Those are part of. But I'm loud, right? Even without the mic. Okay, so we are going to start our session today. And if there's anyone who came in before I introduce myself, or you didn't see me introducing myself, I'm Tabitha Okech. I'm a HTA specialist. Very excited. I'm one of the 2 beneficiaries of the HTA training. That was a collaboration between Kenya, Ministry of Health, and Ministry of Public Health in Thailand. So my gratitude goes to the Ministry of Health for sure, and the efforts that went in, and the dream that started, was it in 2018? Yeah, in 2018, and even the passion that has been, and the interest. Very much to acknowledge the interests that you have shown. Nancy gave me sleepless nights to have this training set up together with Dr. Jared, and I really, really appreciate that you had the interest for us to do this. So I'll take us through the goals and the objectives of this training overall. We'll look at some of the health technologies that you showed you'd be interested in looking at using HTA, the challenges and the limitations that we're having in Kenya, and then I'll show you what we'll cover in this training as well. So the specific areas of HTA, from the Google form that we were filling, These are some of the areas that you highlighted as participants that you'd be interested in us covering this week. So there was health outcomes research, cost effectiveness analysis, comparative effectiveness research, decision analysis, health outcomes research, budget impact, comparative effectiveness research, decision analysis. There was a repetition. There was equity, ethics, and social impact. So I think the areas that were highlighted, if you look at the program, we are going to be able to address each of those areas. Some of the health technologies that you highlighted that you'd be interested in looking at and using HTA process to make a decision on included medical device, not specified which one, all novel technologies, telemedicine. Telemedicine came up a lot. We can discuss that through the week, what the interests are. Costing of health expenditures, use of ICT to improve pharmaceutical services, medicines for hypertension. And we'll see as I'm doing my presentation what that looks like in the Kenyan landscape, decision-making process, policies and regulations that are important. Then we have cancer and NCDs related to health technologies, pharmaceuticals, decision analysis, traditional medicine. Is Dr. Pauline here? She's coming. Okay, nice. Yes, I know we've spoken with her about traditional medicine before and using HTA for decision-making in traditional medicine. Evaluation of medical equipment and devices, medicines in general, dental, x-rays, AI, and its impact on decision-making in healthcare, the development of health technology interventions themselves, even lab processes, diagnostic equipments, and all that. So I assure you that these health technologies that you're interested in looking at, we are all able to use HTA to assess them. So some of the challenges that we highlighted, I don't know if you're able to see, but I'll read, that we highlighted that we are currently facing at work in relation to HTA. I put them into 3 themes: policy and governance, methodological challenges, and capacity gaps. So in policy and governance, we highlighted gaps between the use of HTA and even after there's HTA evidence, implementation of that evidence into policy was highlighted as a big gap, or the process through which that should be done was highlighted as a gap. And policy gap on HTA capacity strengthening intervention, both at the national and the county level. The other thing that was highlighted was price fluctuations in the market and how that poses a challenge to the population itself, those who are not able to afford, but also to the providers of the health technologies, because then they're stranded with their products, and how we can balance that, use HTA process, inform policy, and inform prices of health commodities. Methodological challenges included lack of clear or sufficient evidence in the selection of HPTs to the essential list, complexity of adapting global HTA methodologies to the local context. And I think Dr. Menge, after looking at the program, has also said, it's going to be an intense week. HTA is an intense process that needs dedication as well. It may look complex, but I promise you it's the things we do every day, only that it's put in a more systematic way. Then the decision-making on best options given resource constraints and equity considerations, lack of explicit ways of reimbursing health products, which has been highlighted even in the welcoming remarks, limited availability of local data to support HTA. This came up a lot. I have a different opinion about the availability of data, but we'll discuss as we go throughout the day. Decision-making process and lack of HTA guidelines in Kenya. HTA is a journey, and I'm sure these are challenges that can be surmounted. There was also a highlight of capacity gaps. That's shortage of trained personnel with expertise in HTA, lack of awareness on available trainings, inadequate availability of competent human resource, and also competing tasks. so we are spread thin. So let's see, from what you highlighted when we were filling the Google form for this training, we came up with these objectives to be able to address the questions that you have and the health technologies that you'd be interested in looking at. So one will be on fundamentals of HTA, just the history, what the epidemiological methods in HTA are, economic methods, the social methodologies, including the equity and ethics questions of health technologies, and the processes through which HTA is undertaken in healthcare decision making, how we will synthesize the evidence for HTA, ethical and social considerations in HTA. We'll have examples, and we'll have a presenter on Friday looking at that, and implementation of HTA into decision making, and how to explore the HTA decision making frameworks, identify implementation challenges, and get strategies for sustainability. So this training is basically for any individual who can support HTA technically. So it's a very technical training. So for anyone who's doing technical work, the health economists, the actuaries, public health professionals, you know, if you're doing anything in clinical work, medicine, pharmacology, public health, health policy, this training is for you, for the hands-on work. So we'll have lectures, we'll have group discussions most afternoons to keep us active and engaged. Relevant case studies will be shared, and we hope that you will be able to dedicate full days, the full 5 days, because the morning sessions will be the theory sessions. Most of the afternoon sessions will be the exercises, and the exercises will help us to understand exactly how we do the HTA work, the whole process. So we might not conclude, but you'll be able to understand if, you know, a research body is assigned to conduct cost-effectiveness analysis, what goes into that, so that if someone tells you, okay, this work will not take 2 weeks, it will take a month, you understand why that process will take 1 month and not 2 weeks or 1 week, for example. Then we'll have the course evaluation and next steps, and hopefully in the next steps, we should be able to discuss the future opportunities and way forward on how we can integrate HTA process into our decision making and into the pharmaceutical health benefits package for this particular training. So that's it for our introduction. If there's no questions, I will go ahead and start our session with the introduction to yes, we'll towards as I present, the participants would like to have a link, the website, so that they are able to probably project the presentation as they go. Yeah. If you could share on email. Was the website shared? So we'll look at, we'll do an introduction to health technology assessment and experiences from Thailand and partner countries. So we'll have, hopefully, by the end of this session, we'll have a session follow-up from an African country experience for us to look at. So we look at the overview of the health technology assessment, importance of health technology assessment in policy making, what the components of health technology assessment are, case studies, opportunities and challenges, and next steps on it. So before we delve into the topic for this morning, I would like us to brainstorm a bit. So get ready with your phones. We are going to do a quick interactive exercise. So this is the context of our exercise. I hope you have QR codes. We are going to scan one and be able to answer some questions. So we have a new immunotherapy treatment for cancer that has just been approved for use. It shows promising results in extending survival rates and improving quality of life for patients. However, this therapy is extremely costly and not widely available. So let's explore how we'll make decisions on if to adopt this immunotherapy or not. So please kindly scan that QR code. Don't start answering the questions, just scan, then you open. You'll see the first question. If you're able to see the first question, let me know. Just raise your hand if you're able to see the first question. Okay. Anyone still scanning? If you're not able to scan, there's also a link down there that you can use. Please don't start answering. We'll answer together so that we see what the polling is like. So just be patient. Okay. You want the link? The QR code again. QR, or you can try the link. Google, just go to Google and type the link. Can we start? Yeah, yes. I hope you've been able to take a picture so you can get the link for those who will need to still key in the link. Just take a picture so that you can write it slowly as we go. All right, so for the first question, so just answer the first question first and pause. So our drug has shown effective results in elderly patients who have fewer treatment options and often experience better outcomes. Who will you give it to? Once you've answered, you can submit. Have you submitted? It's not showing. Let me see if I'm using the right link. Okay, just hold on. Okay, I got your responses. Tell them to use the link if they're not. So one more request to scan, one last chance to scan, then we can project the responses. Is anyone scanning? You can take a picture and then you can use it to scan. All right. So I'll project our response for the first. So most of us will give the drug to the elderly only, not to everyone who needs it, okay? Okay, response number 2. You can do the second question, we see. It's not showing. Okay. Should be able to show. Okay. I don't know why it wants me to show different Nini. Like the voting link is different from the polling link. If I put the polling link, it doesn't show the results.
Because I think when we change from your end,
Let's see.
yeah, you see, it says the same.
But I have changed the slide. This is the first slide. This is the second slide.
Maybe it is right. You see? Yeah. Nice.
Okay.
Okay.
All right. So the drug is available in urban hospitals, but not accessible in rural or lower income areas due to cost and infrastructure limitations. Should we ensure equal access to this treatment regardless of geographic or social economic status? Or should we focus on improving access in the areas with the highest concentration of patients who can afford the treatment? Should we ensure equal access to this treatment regardless of geographic or social economic status? Or should we focus on improving access in the areas with the highest concentration of patients who can afford the treatment? Remember, it's only available in urban hospitals, but not in rural or low-income areas. Anyone still voting? Okay. Any more votes coming in? So we ensure equal access to treatment regardless of geographic or social economic status. But in the first question, we decided to only give the elderly. Okay, nice. Okay. So the drug benefits are seen over long term, favoring younger patients. But the elderly experience more immediate quality of life improvement. So will we prioritize the younger patients who are seen to have long-term benefits, or will we prioritize the elderly who this drug will give immediate improvement in the quality of life? Who will you give the drug to in this instance? Keep voting, keep voting. No abstaining. No abstaining from votes. No spoiled votes, please. It's a hard one, but you have to pick a choice. You're the decision maker there, and you have to avail this drug, and you have to make a decision who you're going to avail it to. Tunapea nani? Sasa kwa hawa wawili. Still the same drug. Who are we giving now? There's someone who abstained from voting the other time. Please, don't refuse to vote, eh? Okay, so now we are giving the younger patients. All right, let's keep going. Decisions are hard to make. You can only give the drug to one person, and you have two people who are diagnosed with the cancer, and they need the immunotherapy. You have a younger, richer patient. You have an elderly, low-income earner who needs this drug. Who are you going to give it to? Remember, this is the same drug that has greater benefits in the younger person, but more improvement of quality of life in the elderly. It's very costly, not available in the low-income setup, but you have a younger, richer patient who needs it, who definitely will show more benefits. Who are we no abstaining, please. Vote. Vote. No passing. Yeah, no passing. You have to save. You have only a chance to give one person the drug. Please. I'm waiting for more votes. No abstaining. Doc, vote. Eh? Don't be stressed.
Who is paying?
Who is paying? Vote, 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 vote. Who are we giving the drug to? The other one can buy. But they are under insurance cover. Both of them are. Okay. Okay, let's assume they're not. We don't have that information. We don't know if they're covered or not. But we are making a decision. What if both of them are covered, but you can only give the drug to one person? The elderly can die raka. The younger one needs to live longer. They have more energy to work. Eh? Okay. Voting. No discussions, voting. All right. So, given the high cost and limited availability of the immunotherapy, should the decision to allocate this drug be prioritized to patients with greatest potential for long-term survival and recovery, that's the younger patients, or to patients with the greatest needs and immediate benefits, who are the elderly patients? Who are you going to prioritize? The drug is of high cost, limited availability. Who are we going to give the drug to? Because you can't give all the population who need the drug. Who are we giving the drug to? Keep voting, no abstaining. If you contradict yourself as you had answered previously, just know that's how decision points are sometimes, right? Yes. So we'll see how to address when we get to these decision points and it's so hard to make a decision. So just vote. there's no names to how you voted, so I don't know who says what. So don't worry. Okay? 2 more people. Who is this abstaining from voting? Thank you. All right. What if the number of patients who could benefit from the immunotherapy exceed the available supply? What criteria will you prioritize to allocate this medication? Will you look at age? Will you look at the social economic status? That is the rich versus the poor. The rich can afford, so you give the poor. Will you look at the geographic access? It's only available in the urban. So you'll say, okay, whoever is able to get to the urban area will get it. Those in the rural, if you're not able to come to Nairobi, pole. What will you prioritize? Age. Wale wakongwe wako nyumbani wajipange. Wow. Okay, keep voting. Keep voting. Please don't abstain. We have to make a decision for the Kenyan population. Okay. Thank you. Thank you for those votes. Decisions are hard to make. Yeah? Okay. So those are the dilemmas that we have, right? So what do we conclude? Who are we giving this medication to? The elderly? No, we have said you are giving it to the young population. You are prioritizing age. And you are giving it age by older or younger? Older? Younger? Okay, let's see. Let's see how we are going to make that decision. If we say by chorus, the loudest will have the day, right? If we say nays and a's, all for the elderly, yes, yay. All for the young, yay. Okay, so let's look at what health technology assessment is. So we know that health resources are scarce. We don't have limited resources to be able to address all the health needs that we have as a country and even globally. There's always one challenge coming in and going out. There's always one other sick person. There's always a new pandemic coming in, or there's always something that needs to address. And money doesn't always buy better health. So there's this study that was shown that 20 to 40% of all health spending is actually wasted through inefficient use of resources. So how can we make better decisions to ensure more efficiency in healthcare spending? And in healthcare spending, majority of the things that we're going to spend on are the health technologies, including the diagnostics, the treatments, the decision-making processes, and all that. So health technology is the application of organized knowledge and skill in form of all these things, the health devices, medicines, vaccines, even processes and procedures are part of the health technology. So what is health technology assessment? I think in the welcoming remarks, Doc really summarized it well, what the dilemmas are and what we need to do and how we need to do it. But there's a well-documented definition of health technology assessment, which is a form of multidisciplinary policy research or process that systematically examines the short and long-term, direct and indirect, and intended and unintended medical, social, economic, and ethic consequences of, one, we start from development, developing a health technology, implementing it or diffusing it, and its application as a set of related technologies or technology-related issues. So it could be the health technology or the decision point, the process, or the procedure. Even the public health intervention processes can be assessed through this policy research methodology. So HTA involves technical and procedural elements. The procedural elements are what we were talking about when we were talking about policy and governance gaps. Those are the things that we may need to align and work on as a country to be able to implement the technical bit that is already being done here and there without knowingly or unknowingly that it's part of HTA. So for the procedural elements of HTA, we have the topic nomination and selection. How do we decide what we are going to generate evidence for or appraise to be included in the benefits package? Is it the people who will lobby and decide, the people who lobby the most will consider those topics? Oh, to a spinal injury, they've really been bugging us. They want their interventions included in benefits package. Let's contract a researcher, to give us evidence if we should include these interventions or not. What process are we going to use? How are we going to make the assessment? And who is going to make that assessment? Is it the TWG that is working on the benefits package? Or are we going to contract someone that already does that work anyway to assess the health technologies that we're interested in, considering for inclusion in the benefits package? And then the appraisal and the decision process. Who does the appraising? Is it the benefits panel? Is it the TWG? What are the structures in place and that inform how the appraisal process takes place? And then dissemination of even the evidence that have been assessed and provided. How do we disseminate it? Do we do policy briefs? Who disseminates it? Do we gazette it as a country? And we will see what other countries are doing that we may be able to learn from and start to align our processes as a country. And then implementation and the impact of those HTAs. How do we even monitor if the HTA processes that we've been undertaking are actually adding value and are saving us costs? Or maybe we are incurring more costs to generate all this evidence and eventually it's not working. And we'll see how this could happen on day 5 when we're talking about health policy and implementation of decisions. Okay, so the technical bits include the economic evaluation, epidemiological evaluations, the equity and ethical reviews and social impact assessments that occur around a health technology. So there are key components of HTA. One, the type of technologies or the interventions, and we've looked at the health technologies themselves, and the criteria that we will consider when undertaking a health technology assessment process. So for the interventions, it's all the things, the medicines that we have, the vaccines, the medical devices, procedures, surgical interventions or procedures, service delivery models. You can actually use a HTA process to assess if a model, for example, to deliver vaccination, do we want to go to schools? Or if we are doing a mass drug administration, do we want to target schools and only go to schools? Or do we want to go to the whole community? And which one will give us the most benefit? If you want to do disease elimination, for example, over maybe 5 years, what model will actually get us there within the 5 years at the most cost-effective way? Then we have population-level health interventions, so public health interventions. When you want to do lockdowns, for example, there's a pandemic, there's quarantine, there's lockdown, there's social distancing. You can use the HTA process to be able to assess like which decision will give you the most impact. If your priority, the criteria that you want to look at is cost effectiveness or cost saving or the economic bit, social impact. If you want to prioritize social impact, which intervention will give you the highest social impact or the greatest reduction in the disease burden. So the criteria include the effectiveness of the intervention. For treatment, you look at safety of the treatment or safety of the intervention or the procedure for surgical interventions, cost effectiveness, budget impact of introducing that intervention or health technology, issues related to privacy and confidentiality. I wonder if we usually really think about this, but with the digital health, I think this is really coming up. Access to individual data, sharing of data, how do we consider that in privacy and confidentiality? When you're talking about diagnostics, what is the validity of the test? What is the sensitivity, the specificity of the diagnosis tech that we are talking about? Do we ever think about psychological harm or of results? For example, like what is the impact of a diagnostic test that is a false positive, for example? I think we've seen even in the media, people sharing that they started on chemotherapy treatment and then they actually didn't have cancer. Have you seen that before? Yeah. So what is the impact of that, and how can we reduce or eliminate occurrence of those instances? That means that how can we assess the diagnostic tools and ensure that the screening tools or the confirmatory tools actually reduce the number of false positives that we'll have. And we'll see that this week. Benefits of screening, right to get access to treatment, equity consideration, cultural and social values. There are cultural issues on screening, on prenatal screening, on abortion, on HPV. How do we go about and actually assess that as we introduce new technologies? So there's a lot that goes into HTA. Most of the times we've narrowed down HTA to economic evaluations. But as you can see, there's so much more that goes into consideration of decision making through the HTA process, right? Yes? Yes. So I'll look at some of the criteria and just highlight what they will look at, and we'll elaborate them as we go. So in clinical effectiveness assessment, we evaluate the safety and efficacy of health technologies. We consider different things. We consider clinical trial data. We can do evidence synthesis through systematic reviews, and even use real-world evidence. What are the experiences? What are the experts saying? What are they observing that is happening? Even we could have the essential medicines list, but the experts could say, you know what, we have this drug that has been documented in the Kenyan essential medicines list, but there's a new drug that has been shown somewhere to be working. Can we consider it for inclusion or for reimbursement? Yet it's not time for us to review the essential medicine list. How do we address that? For economic evaluation, we compare cost and health outcomes of different technologies, and we'll see how that is done. Mostly we'll use the cost effectiveness analysis, cost utility analysis. There's also cost benefit, cost minimization, all that. But in HTA, you'll see a lot of cost effectiveness analysis, cost utility analysis being conducted. Then we have the ethical and social legal consideration, which addresses the ethical dilemmas, the equity issues, and patient preferences. I think in the morning in the exercise, we had a lot of ethical and dilemmas and equity issues. Did you experience that in the questions? And we were very conflicted in making decisions. The older people voted for the drug to be given to them. The younger people voted for okay, I'm joking. But that's how it happens. Sometimes when it gets to subjective decision making, we come back to ourselves and we make that decision what will really benefit us. And we see that happening even with our legislators, right? Sometimes there are legislations that do not benefit, and those legislations will not go far. So that's how the human mind is. And those social aspects and the ethical dilemmas, then we should be able to address them in a systematic way. So that if the Gen Zs are the ones that are in this room and they're to make a decision on a health technology, if we have a process or a system or a guideline on HTA process, the decision they will come to will almost be the same as the decision that their parents or their grandparents will make through the same process. So that's what we are hoping that we can replicate with the HTA process. So some of the methods that are used in HTA, so for us to gather evidence to make decisions, either we can use primary data studies or we can synthesize studies through interactive methods. So primary data studies include the clinical trials that Mutono was talking about that is done by SEMA. We do comparative and non-comparative studies, use control groups, all those different study types that will be highlighted tomorrow as we go in the epidemiological methodologies. The interactive methods or synthesis methods include the systematic literature reviews, meta-analysis, modeling that we're also going to look at this week at some point, So the decision trees, the Markov models and all that. There's also group judgment. So consensus development. We agree that, okay, we've assessed these health technologies. There are some that are at the borderline. Which way do we go? Do we adopt? Do we not adopt? We come up with group judgment, consensus. We do a Menti survey and we vote. And then we can also have unstructured literature review, just source for not through the systematic way, and have expert opinion. So probably we've had a group judgment, we have a consensus, then we ask the experts, what do you think, like from your practice experience? Does it make sense for us to adopt this health technology? Is it practical within our system? It could be cost saving, but there's no expertise to be able to provide that health technology or intervention out of a particular geographic region. So how else can we implement that intervention for it to take place? So there's a lot that goes into consideration for adoption of health technologies through HTA. So some of the challenges for applying HTA includes when a country is applying the universal, rolling out or in the journey towards universal health coverage, when they're designing health benefits packages, review of national list of essential medicines, when you're doing price negotiations for health technologies or medications. Do we do price negotiations before we include some of the medications into the national list of essential medicine? Do we? Not really. Yeah, so I'll share an experience from countries that actually do price negotiations using the HTA process to be able to provide medications that seem out of reach for their population, and they see the benefit of those medications. Public policy evaluations, treatment guidelines. I mean, it's the whole array of things, and there actually there's a study that has been conducted to show the countries that conduct HTA what they focus on. And the main focus actually has been shown to be planning and budgeting, clinical practice guidelines, HTA process for clinical, designing of the health benefits package, protocols for public health programs. Imagine even using HTA for development of protocols. People are serious out here. Public procurement of medicines, quality of care indicators. And I think Kenya is in some of this have already been implemented. Some of this we're in the process of implementing and looking at. So it's a good learning curve. And I hope one day we'll be able to make decisions in a systematic way. So let's look at universal health coverage as part of the where we can apply HTA. So the SDG goal number 3 talks about good health and well-being. And we want to provide ensure healthy and productive well-being, right? And promote well-being for all ages. All ages? We just prioritized young people in the morning a few minutes ago. Anyway, we want to provide and promote good care, healthcare for all, right? And this cube is a bit too familiar to all of us, right? So we want, in this cube, it shows like the current pooled funds, what funds are available and who they're able to cover. And then it looks at who is covered in the blue and who still needs to be covered for us to achieve universal health coverage. And then on this other side on services, which services are already covered and which ones are yet to be covered to achieve universal health coverage. And then when we go up, we look at funding, right? So we want to reduce the out-of-pocket expenditure and be able to cover people from catastrophic costs. Where are we in Kenya? What percentages? Pardon? 5%. On which side? So do we know what populations we are covering currently and which ones have been left out when we look at equity issues? Do we? And for the services?
Look at insurance.
Yes.
We can quantify the percentage.
Yes.
But you know the other input financed, prioritized, vulnerable groups.
Yes.
Not has been brought to insurance.
Uh-huh.
So it's a mixture.
It's a mixture. And when we talk about equity, there's a group that is vulnerable that is missing out. Yeah? Especially? Men. Men are okay. Yeah, through other mechanisms of financing. When we have the vaccination programs, it's already fully financed. Linda Mama, there's a debate about it, and we'll see how that impacts and what should be done. What can HTA process inform? How can HTA process inform that decision? So interesting times. Even services, like what medications have been included in the benefits package, even the one that we have currently, the social benefits package for the social health insurance. What was left out? Why was it left out? So yeah. We have, so decision-making processes, we can use HTA for decision-making processes. Currently, and I saw it highlighted in the challenges that we are facing at work in relation to HTA, a lot of the decision-making processes are implicit. We use historical allocation. If we gave this percentage and amount has increased by this percent, then we just mark it up to a certain level. So we have base funding decision on what has been funded traditionally. There's no formal approach to prioritization sometimes. Sometimes there's a process and a decision and lobbying that goes into it and a lot of evidence generation. But we reach a point where there's no evidence and then we go the subjective way. We use informal and clear considerations for the noise making that I was talking about. The people who are able to make the most noise will be listened to the most. And there are people who sometimes they need the intervention more, and yet they don't have a voice. Who listens to them and who is able to advocate for them at that table? A process is able to advocate for them. So we need explicit priority setting processes based on clear decision-making criteria. And that are evidence-informed and transparent. So HTA is very transparent in that sense. So let's look at these health technologies. You're a decision maker. Which of these health technologies will you include in the benefits package? What criteria will you use? And how will you make that decision? Just think through it. We'll not delve into this. We'll do this in the afternoon, more of this in the afternoon. But if you have hormone replacement therapy, you have mental illness treatment outpatient. I don't think that's covered currently in the health insurance, is it? Outpatient medications for mental health. Rehabilitation. I know rehabilitation is covered in patients. Assessment for disability among people living with disability. Is it covered when someone comes for assessment for them to be able to get that card to get benefits? Probably not. Which one will you prioritize? Home-based palliative care. Is home-based palliative care covered? Yet we say when someone reaches a certain stage, then there's nothing more we can do, and we don't need to keep them in the hospital. We need to do palliative care at home. Who takes that cost? It's still a cost. Yes, if you've had a cancer patient and you're providing home-based care, you will realize the cost is massive. There's prevention interventions. We're talking about circumcision, opportunity infections in HIV, HIV medicines themselves. We are talking about glucose strip for monitoring blood glucose. PCS screening for prostate cancer, heart failure. We're talking about telemedicine. If you are to do telemedicine, who is going to cover the cost? Are we covering the cost in the benefits package? But we are saying telemedicine is cost saving for both the patient and the system. But who is taking up that cost? If I'm to set up, I'm a health professional and I can monitor my patients online, is the social health insurance going to cover that as a consultation? And where is it billed at? In which facility? Is there a point where that is billed? Yet it's been shown to be cost saving. Yeah, so how are we making decisions? Viral load tests for HIV positive cases. I think more and more funding is going down for monitoring for viral load testing. If there's a new drug for liver cancer in treatment. So you have all these health technologies, and probably you need to prioritize only. The funding that is available can only fund maybe 3 or 4. How do you make a decision on which one to include in the benefits package. Which one is more important than the other? The one for cancer, the one for chronic infections, the one for people who are vulnerable, like people with disabilities or mentally. Ooh, how do you prioritize? Okay, so let's look at something else. So in the current, I think this is the previous budget for National Health Insurance. So I borrowed this from the Health Finance team. The high budget impact interventions, this is what was highlighted. And what comes at number one? Hypertension. I think as part of those technologies that we highlighted that we'd like to look at, someone talked about medication for hypertension. And you can see the amount of budget that it takes up. And that's for long-term management of hypertension. May we need to probably go back and review and look at the decision points and how we can cut cost on hypertension. Is that possible? Could that be something that we can prioritize as DHPT? Because most of this is actually medication, right? That goes into medications, management for the complications due to hypertension, and just like daily management of that hypertension itself. So that's something for us to think about. So I looked at the, who is the timekeeper? Please let me know when my time is done. I'm a lady of very many words. I'm good on time, okay. All right, so for the Kenya benefits package development, so I looked at the process that they shared, the Health Finance team shared what they looked at, and highlighted in red some of the things that we could look at further. So for example, so this is the process that they undertook to develop the benefits package. So identification of services for potential inclusion. So the Kenya Essential Package of Health was a starting point. And then they prioritized any other additional health technologies or interventions that have been prioritized in the WHO UHC Essential Package. Then it was really not highlighted if there was input from subject matter experts, but I know there's a stakeholder engagement that took place, and the noisemakers, okay, at least people were able to give their inputs. Sometimes those inputs, then the people who are loudest are maybe listened to more, especially when there's a lot of pressure. So that's why I highlighted that. In the costing of the package, there's the Ministry of Health costing for public health, the primary health care. It's time for tea. I'm being told I'm taking up your tea time. I'm winding up. So there's costing that was done for the primary healthcare services. And was there costing for emergency services? There's some costing that went into emergency services. What about secondary data for unavailable cost? Was there any consideration for secondary data from other countries then that we can adopt to the Kenyan context? So those are some of the gaps that were there, because some of the interventions that were not included, the reasoning was we are not able to establish what the cost is like, or some costs were really low, and it's because there was no evidence from our country. But we are able to adopt that evidence from somewhere else and adjust it to our country, especially for costing data, and we'll see how that can be done, I think on Wednesday. Then for higher level, level 5 and level 6, costing has not yet been done, but there are services that may not be are not provided at the primary health care level that needs to be provided here. Then how do we determine the cost? Then the next step was to get data on population need and current coverage for the benefits package intervention. So where data was not provided, then we are not able to estimate and cost. And just by that, some of the crucial interventions may be missed out from the benefits package. So how do we address this? You talk to maybe people in mental health, and they're not able to establish this. How do we estimate using the global figures and make sure we don't leave this population out? They are vulnerable. Those interventions are needed, but someone is not providing that data. How do we still address that? So we'll see how to go about that as well. Then the next step was to compute total intervention costs and budget impact using the estimates of population burden. So there was MOH utilization that was used and adjusted to reflect population demand. Were interventions considered together with their comparators? So this is where the HTA process comes in. So probably we are looking at what was already in the essential package, which may have been developed a couple of years later. New technologies may have come in. When we're getting to this point, we're looking at population burden. Are we also looking at other options that would be cost-saving that would help us to actually onboard more interventions for reimbursement into the package or not? Then determination of yield, which was still ongoing. How do we optimize the health benefits package? Which ones are the high budget impact? We've seen what the high budget impact interventions are. How do we address that? How do we ensure that we still get the most and optimize our health benefits package? The products that are donor funded, with the reduction in donor funding, how do we onboard them without overwhelming the budget that is available? How is copay for expensive interventions addressed? Is it addressed in the essential health benefits package? Is there an option for copay? No. But there are countries that have had that conversation. And is that a conversation that if you tell me I'm 100% going to pay for an intervention that I need that I don't have, and you tell me, okay, I'll pay 50%, look for the 50%, which one is better? Yes. So how can we reach a point that we say, okay, for this intervention, it's not cost effective. But if you pay 50%, the country is able to fund. And then the patient now needs to look for the other percentage. How do we arrive at those decisions? Then there's validation with stakeholders. So at every point, you need to engage the stakeholders as well. So this is a process that was undertaken, but I was trying to highlight some of the places that we may need to think about as you think about the pharmaceutical health benefits package. So these are the other things that we may need to think about that we may not have had a chance, or the team may not have had a chance to think about as well. Okay, so importance of HTA in policy making. So I think this I've really highlighted, and Dr. Menge summarized it really well. I don't want to belabor on it. We want to enhance evidence-based decision making, ensure allocation of resources with the greatest benefits, and improve efficiency of healthcare spending, and support sustainability as well. So let's look at the global level. So for the global level, this framework is very familiar. I think you have seen it for those who've done some HTA work. Even in the draft strategic framework, it is there, adopted from WHO. We look at the inputs. What are the inputs that we need for HTA? We need the legislation, the governance structures, the committees, the appraisal committee, the assessment committee. We need the resources, both the human and financial. What activities do we undertake? The assessment. Where do we get the data? Who analyzes that data? How do we report the data that has been analyzed? How do we disseminate our findings? Who does the appraisal? Who are the stakeholders? And how do we engage them? For the HTA process, it is multidisciplinary, heavily on stakeholders. You're talking about pharmaceutical benefits package. We have the manufacturers of these medications. We want to do price negotiations. Who are we going to negotiate with? It is the manufacturers. But you want to bring them on board to negotiate at the end when now you've determined what that price is. But you didn't bring them on board when you're starting and nominating a topic and saying, we have a problem. We have hypertension in our country. This is taking the biggest budget. We want to look for medications that really we are able to accommodate within our budget. So this is the process that we're going to undertake. These are the people who are going to give us evidence, give us the options. This is the process that if you find that this price is better, are you able to adjust your pricing so that you don't ambush them at the end when you've already made a decision and you've gathered all that evidence? Stakeholders every single day, even the patient themselves, and they're patient representatives when you're making these hard decisions. When you're deciding a young person is going to get that medication and not an older person, is there balanced, equal representation from the population level, civil society? So yeah, HTA is quite a process. So the pricing, the horizontal scanning and all that, to get what the gap measures are, efficiency in spending, give recommendations and all that. And eventually want to improve health status, increase coverage of UHC, and greater access of health services. So the more we cover the services, and we reimburse for the services, the more we are able to cover a bigger population. The more population we cover, the more we are able to reduce the out-of-pocket expenditure for these people. So horizon scanning means we have the health technologies that are already in the health benefits package. But research is ongoing. New interventions are coming in. How are we able to stay on course and stay abreast? How are we able to ensure that we are not holding to health technologies or interventions that we probably made a decision on 3 years ago, and the only other time that we are able to review our essential list is in another 2 years. So 5 years, in 5 years' time, so much has changed, right? How do we keep making sure that we know that there's a new hypertension drug that is way cheaper than what we have in the health benefits package? How can we onboard it and get people to use it? Or how can we identify those health technologies or interventions that have been identified to be groundbreaking or are adding value to patients, and not wait for another 5 years to include the benefits package? Maybe there wasn't a drug for a certain cancer, and when we're doing the essential medicine list, 1 year down the line, it's approved, or 2 years down the line. How do we ensure that the population gets it earlier than later when we are then? So horizon scanning makes sure that we keep up to date with what is going on regionally, globally, internationally, what is new that we should be able to consider for reimbursement as well. All right. I think when we're having the discussion behind there with Dr. Menge, Jared, and Nancy, this is what we're talking about. Like, what are other countries doing when we are making decisions? What steps are we undertaking? So if you are requesting for HTA support, what questions we need to ask ourselves? What level of support does the decision maker need? So maybe the Ministry of Health is requesting for HTA support from the research organizations. We have Cambridge, we have SEMA, we have all these people. What questions do you want the evidence generated on? And what is the defining HTA process? What is the structure of governance that is available? Who will even request for this evidence? Time. Okay. So we break for tea first and come back. I think I'm almost done, actually. I'm being guided to let you go for tea first, then we can come back. So let me finish this slide, then we can have tea. Then we have healthcare technology decisions. Problems, what is the question? What is the problem and what research is needed? So as we request for support to make a decision, what do we want to answer? In policy analysis, how should we research? How should the research be conducted? Are we going to actually do primary research data collection? Are we going to use already published evidence to do thematic reviews, meta-analysis, and all that? Are we going to use models to make a decision? Recommendation, how should the results of the research be put into context? And how should the decision be made? Who makes that decision? Who implements it? And where is that decision being communicated? Are we gazetting it? Are we writing a policy brief? What method? So these are all the things that we need to think about when we are doing the HTA process guideline and when you're doing the methodology guideline. So we have a long way to go, but it is a doable process. And we have people who have gone through this journey that can help us to decide. So I want to pause there by directives of our hosts and allow you to go proceed for tea. Then we can come back and I wind up before we have the next session. And I'll take up questions after that. So keep your questions kindly. But let's have tea.